case history taking and Socrates. When do we use Socrates? When taking a history. Generally speaking, it is best applicable to situations where the patient is complaining of pain. In situations where the patient might complain of, say for example, weakness or temperatures or any other complaint for that matter, this template is probably not the best to utilize. So what exactly does Socrates stand for? Each of the letters that the acronym spells out has its own meaning, and we've got to explore each avenue. So S is for site, as in where exactly the pain is, the location. If there are multiple locations, we've got to appreciate and understand or otherwise consider the likes of a pathology that may cause migratory pain, for example polyarthralgia, which means pain in many joints. Then we move on from that to the onset. When did the pain actually come on? How long has it been there for? And with onset, you want to consider the duration, but what's also equally important here to consider is has the pain changed in any way, shape or form? Has it worsened? So let's say for example the pain has been there for 4 days. Was it like that initially, or was it less so? Has it worsened? And if so, at what point did it worsen? After how long did it worsen? Or alternatively, the pain started 4 days ago and it's actually improved, or it's changed in nature. And the change in nature is precisely what takes us nicely onto the next question, i.e. the character of the pain. So how would you best describe the pain? And that's perhaps one of the best ways to ask the question. Patients may find it difficult, but good cues, once you've given them an opportunity with an open question, are to give them some prompts. And in the situation for character, you may consider pain that is it an aching sensation? Is it dull? Is it gnawing? Is it tingling? Any burning sensation, what we call causalgia? Any sharp shooting sensations? And otherwise we could look at visceral pain, which might be colicky. Is it wave-like? Does it come and go? And on the back of coming and going, is this pain constant? Is it there all the time? Or does it come and go? Is it intermittent? And that is again another aspect of the character that we must explore. Moving on from the character, generally speaking, with the onset, the next question that you might consider in the context of pain is any associated history. Did you do anything that might have actually caused the pain, that is responsible for the pain? For example, did you pick up something heavy and that's what caused the back pain to come on? Or have you engaged in a DIY project for which reason it is that you've now got pain in the lateral aspect of the elbow? That might explain it. So any activity or associated history. And in the given situation, sometimes you may have to actually go back a few days. So in the context of lower back pain, for example, you might say, okay, you woke up with the pain. What did you do the day before? And the patient often, oh, actually, I moved the sofa, I lifted the sofa, or I did a DIY project, or I was out there gardening and I pulled out a tree stump. So sometimes exploring the history a few days prior to the actual onset of pain is also crucial in the diagnostic process. After character, we'll then move on to radiations. And again, we won't ask the patient, does the pain radiate anywhere? Rather, we'll ask the patient, does the pain actually travel anywhere else? So for example, in the context of chest pain, do you feel the pain in either of your arms or the neck or the jaw? In the context of shoulder pain, does the pain travel up into the neck? Does it give you headaches? Does it go down the arm? Any pins and needles, numbness, weakness, or funny sensations down the arm? And these are neurological symptoms in a musculoskeletal presentation that you may appreciate and give consideration to, because you've got the nerves that also pass the area and you want to be sure that the nerves are not involved. After the radiation, we can then go on and ask for associated symptoms. So are there any other symptoms that are associated with the pain? Again, if I go back to the chest pain, the patient may say, oh actually yes, by the way, I've also got a bit of nausea that's been going on. Oh, there was also sweating and I felt very clammy. In the context of, say, back pain, for example. Oh yes, I've also had a change in my bowel bladder motion. So symptoms that may be associated in the context of abdominal pain. The patient may say, with the pain, I've also been feeling nauseous and I've been vomiting and I've also got loose bowel motion. So these are symptoms that, and the way to ask this is any pain, any other symptoms that you've noticed that have come about since you've had the said presenting complaint. From the associated symptoms, following the template, you'll go on to the timing. Is there any timing to this pain? So is it worse at any particular time of the day? Is it worse in the morning or is it worse in the evening? And this again will help you to rule in or rule out or otherwise hypothesize the likelihood of some inflammatory processes or some rheumatological conditions. After the T, we'll then move on to E, referring to the exacerbating and or relieving factors. Now there are 2 questions on this one, and always ask the 2 questions separately. And the way to ask this is, have you taken anything that might help the pain? Have you noticed anything that makes it easier? And if they're not sure, or they say, well, I'm not sure what I could have tried, have you tried any painkillers, any anti-inflammatories, any heat? Does the brushing you make it worse or better? And then from there you can go on to the aggravating factors, so exacerbating or aggravating factors. So is there any particular movement that makes it worse? Any activity, for example, in chest pain? Oh yes, it's actually nice and comfortable now, but when I exercise, it becomes worse again. Or in the context of shoulder pain, for example, when I carry out any overhead activity. When I move my arm outwards to the side, then I get pain in that as well. And so these are kind of things. So again, in the context, say for example, on the lateral aspect of the elbow, they might say when I'm trying to open jam jars or turn door handles, that's where I get pain. So exacerbating, excuse me, exacerbating factors are very important to appreciate, because that's what's going to tell us or indicate what structures are actually involved. Finally, we'll move on to the severity. So how severe is this pain? Now, the best way to do this is by means of an analog scale. So the scale that we usually use is the VAS, the Visual Analog Scale. And this goes from 0 to 10. And you must define this to the patient, where 0 means no pain and 10 means absolutely excruciating pain, the worst pain that you ever felt. On a scale of 0 to 10, where would you class this pain? Now appreciate also if the patient is suggesting that actually my pain is somewhat better, or it's intermittent, or it comes and goes in that it's wave-like, which you might want to appreciate, or if they say it responds to painkillers, what you might need to explore is, okay, so when it's at its worst, how bad is it? How would you scale it? And how would you rate it at its best? And how would you rate it at present? So these are 3 separate measurements or notes you can take in checking severity. So that's a Socrates, and each element to that, how you might explore it, how you might ask the questions. But please remember, case history taking is an art, it's not a science. You'll use the acronym, will tailor the actual the consultation, the case history from here, but do not limit yourself to it. Explore. Remember, case history taking is like an investigation. You want to explore all avenues and explore the avenues as deemed appropriate. So when you identify factors that might aggravate it, for example, that might be work associated, such as occupational hazards, explore that avenue and then come back and continue the rest of the history. So as you practice, you'll find that there is an art in its entirety, and you'll start to ask questions outside the template and allow the flow of the actual case history to be more natural rather than rigid or regimented, as might be dictated by the acronym itself. Thank you for watching.